My name is Dominica Essie. I'm the CLE and Sections Manager here at the Cleveland Metropolitan Bar Association. Thank you for tuning into today's CLE on Clinical Research, Law, and Policy. We have a great program in store for you, but before we get started, I will just let everyone know if you're here for CLE credit today, you have to just complete the brief survey that will be sent to you following the program. We do also have a couple of polls that will be administered that pertain to today's program. So just complete those, and those will also help us report to the Supreme Court that you were here today. We also definitely want to take your questions. So as they come into your head, enter them into the Q&A function or the chat, and we will get to those at the end of the program. And with that, I will turn it over to today's chair of the program, Jaleese Thomas. She is the Assistant Director of Case Western Reserve University's Strategic DE&I and Health Disparities efforts. Jaleese, if you would like to take it away, thank you for being here.
All right. Thank you, Dominica. Good afternoon, everyone. Thank you to the CMBA for allowing us to have a space to discuss the clinical research, law, and policy, and how research is one way to eliminate health disparities and advance health equity. I've worked with Dr. Hall and Ashley when I was at University Hospitals in the Clinical Research Center. And today you'll see how we use our roles, backgrounds, and passion for diversity, equity, and inclusion in healthcare in an effort to help everyone achieve optimal health. Dr. Greg Hall specializes in the healthcare of African Americans, including the care of high blood pressure, diabetes, heart disease, stroke, and more. He was named the first medical director of the UH Cutler Center for Men's Health and serves as the founder and executive director of the National Institute for African American Health. Dr. Hall, the floor is yours.
Well, thank you. I'm excited to be here. I start all of my Zoom meetings by talking on mute. That's how I launch, right? At my age, I'm really happy to be here and talk to you, and to really have this discussion about how things relate to health disparities and things of that nature. I'm gonna share my screen and ask you to mentally sort of think about, this is a life expectancy, age life expectancy, and I want you to mentally assign the race and ethnic group to these ages. African Americans, Asian Pacific Islanders, white Americans, and Hispanic Latinos or Latinx Americans, who lives 74.8, and this is 1916, so it's like, look, 1916 data, although it was published in 1918, in 2018, it's 2016 data, and then 2018, 74.8, 78.5, 81.8, and 86.5. So just sort of mentally assign who you think does what. And since you know I'm specializing in African American health, then I'll spot you that the 74.8 is African American. So now that I've spotted you that, they have the worst, who's 78.5, who's 81.8, and who's 86.5. So I'll give you just a couple seconds to sort of think about those other three racial ethnic groups. And now we will go forward. So 74.8 is African American. People are always, my residents and everyone's always surprised that white Americans are at 78.5. Hispanic Latinos live longer at almost 82 years, and Asian Pacific Islanders 86 years. So when I was on the Commission for Minority Health, I, like a whole lot of other people, thought minorities did poor in one way, and then the majority did better. And so when I accepted the position to be over the Cutler Center for Men medical director, I was like, white people have a significant health disparities too, because they don't live as long, almost 8 years less on average than Asian Pacific Islanders and Hispanic Latinos. And so there's work to be done in all those populations, but unfortunately, the worse off is the African Americans. And so that's what we sort of look at. And just so to be equitable, I added a Native Americans at 76.9. Sometimes people ask what that was too. So looking at life expectancy from 1970 till now, the doctors like me, we've done a pretty good job, along with public health experts, really trying to improve the life expectancy for everyone overall. Unfortunately, African Americans still remain, significantly lower. And again, if you break it up by sex, you'll see African American males like myself have the lowest life expectancy, then white males, then Black females, then Hispanic males, and so on, that you can see there. It struck me that the mortality rate, this is again the rate per 100,000 with again, African Americans on the far left and African American males in the deeper blue have the highest. But it sort of struck me that I was raised to believe that women live longer than men, but African American women don't live as long as Native American men or Hispanic Latino men or Asian Pacific Islander men. And even if you compare the United States Blacks to other countries, African American women don't live as long as the men in Switzerland and France and the UK. And so, and then we had a pandemic. And so now we've got even more data in terms of life expectancy, and this is through last year. And what we've seen is there's going to be another dip in the life expectancy for everyone, right? And so when I show medical students and residents life expectancy from 1900 till now, we see that big dip in 1919, and they say, what is that? And now everyone knows that was the influenza epidemic. And so now there's going to be another dip in 2019, 100 years later, curiously that it felt just like that. So that we'll be looking at that, and of course we'll all know what it is as well. Unfortunately, this new data shows that just from 2019 to 2020, Hispanic Latinos lost some time, whites lost some time, but African Americans again lost 2 years, lost the most amount of time just in that 1 year. And then you can, again, breaking it down by male and female, you can see again, African American males absolutely worse, Hispanic males, then African American females right neck and neck, and so on. And so what contributes to these life expectancy problems, heart disease, cancer, the differences, the Black disadvantage is really due to cardiovascular disease and cancer and homicide and diabetes. And so African Americans have the worst outcomes as far as cardiovascular disease. And you see that 321 per 100,000 compared to whites, 245. And you see the rest of them there. So it's not like it's edging out. It's the worst by far, the worst for diabetes. And here you see Native Americans at 45. And African Americans have the worst outcomes for breast cancer, ovarian cancer, cervical cancer, colon. You see them there. And so it's not all cancers, right? But if you were to name some cancers off the top of your head, these would probably be what came out of your mouth. Now, what's not there, and it's not good news, but African Americans fell into second place when it comes to lung cancer mortality just recently. And so they don't have, the white people have the worst outcomes in terms of majority population in terms of lung cancer. And so that's just sort of hot off the presses data. And so at this point, I can kind of stop my my share if I could figure out how to do that. Yeah, and I did. So it's just wanted to kind of let you know the lay of the land. And so all those our advances, when you saw our life expectancy improve across a number of over the years from 1970 till now, what we saw was those improvements were due to improvements in breast cancer treatment, improvements in lung cancer treatments, improvement in all those treatments. And what drove those improvements is research interventions, better technologies in terms of all those things. And so if African Americans are avoiding being involved in research, which they are generally, then we're also not benefiting from the nuanced information that comes out of research as it relates to improving cardiovascular disease or whatnot. Now, I teach the class on hypertension at the medical school at Neomed, and in that class we teach that the medication treatment for African Americans, medication choices for treating African Americans' high blood pressure is different than for an Asian American or a Latino American. And so if you don't know that, then you may inefficiently treat an African American for hypertension. And so these nuanced differences in how the medications work and how the medications improve your blood pressure, all that was determined by a huge study that was done at the beginning of this century that demonstrated that. So again, we're in the dark if we don't know, if we aren't able to measure these differences, include these populations, and so forth. And so, and the same thing, I mean, these differences occur not just in hypertension, but in cancer. One of the huge disparities everyone points to is that white women have a higher rate of breast cancer, but African American have a higher mortality. And so those don't go together. That's a disparity. You shouldn't have a higher rate of something and then have a mortality. More people die, less people get it, but more people die of it. That happens. And so And many times that's because of the biology of the breast cancer in Black women. They tend to get a more aggressive breast cancer. But why is that, right? And so again, research is going to that's how we're going to get that answer. So I know it's kind of a lot of information in a little bit of time, but I just wanted to lay the groundwork on why we spend so much time talking about health disparities, because the data is there. Jaleese?
Thank you, Dr. Hall. And now I'll talk a little bit more about research through the equity, diversity, and inclusion lens. So research, equity, diversity, and inclusion, eliminating health disparities to advance health equity. So what is clinical research? It's human subjects research that is patient-oriented research, epidemiologic and behavioral studies, and or outcomes research and health services research. So if we could launch that poll now, I just want to get a read of the room to know where everybody's at in terms of their comfortability with clinical research. Have you been involved? And then once we have those poll results, we'll discuss so that everyone knows where we are in terms of our knowledge with this at the beginning of the program.
If everyone can complete the poll that just popped up, it should appear on your screen now.
And if you happen to be on your phone, I'll read the questions aloud. And if you want to chime in on one or more of the questions in the chat, please feel free to do that. So the first question is, has your primary care physician ever talked to you about clinical research or participating in a clinical trial? Yes or no? Have you ever participated in clinical research? For example, a clinical trial, completed a survey, etc. Yes or no? My interest in clinical research has blank since the COVID-19 pandemic emerged. Has it increased, decreased, or not been impacted at all? I'm familiar with health disparities, yes or no? That's kind of an unfair question maybe, since Dr. Hall just gave us a great primer on health disparities that we see. And then number 5, I believe that participation in clinical research is a civic duty like voting. Yes, no, maybe in the future. And number 6 is a fun question. It's summer in Cleveland. I'm most looking forward to eating and drinking on local patios, enjoying outdoor concerts, water adventures on Lake Erie, simple pleasures like watching the sunset during an evening walk or having a picnic on the beach, everything that involves the sun, of course. So once those results roll in, we can discuss.
We'll give it maybe 30 more seconds, Jaleese.
Okay, thank you.
All right, looks like incoming responses have tapered off, so I'll share these results.
All right, so for the first question about your primary care physician talking to you about clinical research or clinical trials, we have the majority saying no, and that is not an anomaly. We've seen that these discussions are not happening, and with our primary care physicians being the first line of defense in many cases, this is something that we hope to see change. In fact, University Hospitals has a tool about how to have a conversation about clinical research with your physician that you can download from the website and start those conversations. Have you ever participated in clinical research? Again, majority no. Also, not surprising, most people are not just signing up for them without cause. And there's also the stigma behind it. A lot of people don't want to be either seen or viewed as a guinea pig. And then there's just the lack of knowledge that you don't only sign up for clinical trials or clinical research if you have a death sentence because you have some kind of disease that they're saying you have X number of months to live. It's something that could just improve your quality of life too, if you had diabetes or if you'd like to be a healthy volunteer. And oh, great to see that everyone's interest, most people's interest has increased since the COVID-19 pandemic emerged with all the commercials and vaccination talk and disinformation, misinformation. Just really glad to see that people are taking more of an interest in that. I'm familiar with health disparities, almost everyone, and half of our group believes that participation in clinical research is not a civic duty like voting. And that was just a pure curiosity question there, but something that we would like to see supported. So again, that we can have equity, diversity, and inclusion in research, because we know that a lot of the barriers to participating in research are rooted in social determinants of health. So if it were treated like voting, where you have time off to do it and really elevated, we think that more people might choose to participate, and at least at minimum would be able to. And of course, for the fun question, great to see that everyone is looking forward to do something in this summer heat. So thank you very much, everyone. And thank you, Dominica. All right, so what is a clinical trial? It's a research study in which one or more human subjects are prospectively assigned to one or more interventions, which may include a placebo or other control, to evaluate the effects of interventions on health-related biomedical or behavioral outcomes. And what's interesting about this is, there are many types of clinical trials. There's pilot studies, feasibility, prevention trials, screening, so like screening for prostate or breast cancer, treatment trials, cohort studies, case control studies, and cross-sectional studies. And as an example, you'll see a lot of headlines. I'm kind of a journalist at heart, if you will. I love to see that these things are being talked about now. And I think it's really important for us to take note that there is a lot going on in this space. And there's a reason why a lot of the headlines are talking about clinical research. As an example, Moderna released preliminary results in June 2022 from a clinical trial involving their updated coronavirus vaccine that targets the Omicron variant. And they call it their lead candidate to serve as a US booster shot in the fall. So that's just an example of a clinical trial. Equity. So it's the quality of being fair and impartial. So with this, when we think beyond general health equity, as we defined earlier, one area where equity is also urgent is in the research space, as it pertains to research equity and who is receiving credit for advancements. When we focus on health disparities research, an area of research that has been underfunded and undervalued, there is great room for growth. There are concerns that health disparities research is not innovative because it solves for problems that some argue are already addressed. And there's a great disinterest in the area that we could solve the problems better and to impact more people. That just right now is not as appealing as some of the other research areas that are highly funded. And another call for support and action falls on those who are now interested in capitalizing on the health equity or health disparities research space, and they build off the work of scholars without appropriate citation and little intentionality in how they claim their work differentiates from foundational discoveries in the health equity space. And overall, this negligence in appropriately compensating people, either financially or through citation or authorship opportunities, it really does a disservice to the research space as a whole. And, asking someone for time to pick their brain about a space that they've dedicated their whole career to is just something that you wouldn't see in other areas. And we want to make sure that we impart those principles of DEI in everything that we do, but especially in biomedical research, because it does impact everyone. So with diversity, the state of being diverse, variety, the practice or quality of including or involving people from different backgrounds, genders, sexual orientations, etc. This is also an interesting piece. In 2021, the American Medical Association adopted a new policy to increase diversity in the physician workforce, much like the efforts that we see in the legal field. The biomedical research workforce is built on physician or clinician scientists. So when we diversify this pool, we'll inevitably diversify the biomedical research enterprise. The AMA's plan outlined policies and interventions that can increase racial, ethnic, gender, and socioeconomic diversity among the physician workforce. So that's great to see. And then according to an article published in Bloomberg Law, citing a national academics report, diversity will continue to play a greater role in drug and research reviews. Continued lack of diversity in clinical trials will exacerbate health disparities in the US unless the biomedical research enterprise makes systemic changes. So much like systemic racism, if we don't address it at the system level, we will not see the change and impact and outcomes that we really want to see for everyone. And these systemic changes include diversifying the biomedical research workforce. So from the physician level to our study coordinators, nurse research specialists, and staff that support the great research that's done at many of our institutions. And this has been proven to play a key role in whether patients become research participants. based on trust or lack of trust in the medical institution. Inclusion, the action or state of including or of being included within a group or structure. When we think about inclusion and whether or not we are effectively creating environments and cultures that are truly inclusive to those who have been historically excluded, the best person or people to ask is those groups. And the same applies to research topics like climate change. Are we thinking in an interdisciplinary, collaborative way and acting on those thoughts with urgency? So health disparities define preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. One word from this definition that I'd really like us to hone in on is the fact that these are preventable differences. And the fact that we don't prevent them is negligence. It's a willingness to allow the status quo to prevail. What makes the incidence of disease, injury, or violence preventable? How can we avoid promoting systems that avoid outcomes where everyone is achieving optimal health? One way that local healthcare CEOs shared during a panel at the American Hospital Association's Accelerating Health Equity Conference last month is by collaborating to solve health inequities. Cliff Majerian, CEO of Metro Health, said, "People affected by health disparities fall between the cracks of fee-for-service medicine. That's unacceptable." I couldn't agree more that it is unacceptable because anything that is preventable, meaning we have the raw tools and resources that could aid in prevention or avoidance and need to do one more thing like collaborate to help people achieve optimal health, is a choice. If we're choosing not to use what we have and know to help everyone achieve optimal health, then we're willing participants in the health disparity crisis. So we'll focus on each of the elements that I just shared too in terms of disease, injury, and violence. So with disease, and again, these are ripped straight from the headlines. You see June 14, 2022, researchers report that the life expectancy of Native Americans plummeted by nearly 5 years as COVID-19 ravaged the country. The loss in longevity from 75 years for women to 70.4 and 68.6 years for men to just under 64 was far greater than any other ethnic group and about 3 times higher than whites. What contributes to this? Native Americans often lack access to vaccines, quality healthcare, and transportation. And these barriers can be echoed against or for any of the racial and ethnic groups that have been historically marginalized. And for African American men, here's another example. The risk of dying from low-grade prostate cancer is double that of men of other races. Studies show that despite the low grade, meaning how likely it is to grow and spread, doctors may be underestimating the risk of death from low-grade prostate cancer in African American men. And then with injury, so these two headlines are relevant to Cleveland, if not from Cleveland. We have the first one, according to a 2016 study commissioned by the USA Swimming Foundation and researchers at the University of Memphis, 64% of Black children in the US can't swim, compared to 40% of white children, and they are almost 6 times more likely to drown in a swimming pool. Just as representation matters everywhere, not seeing people of color in aquatic sporting events and lack of access to swimming lessons and pools compound the historical segregation of pools. And in urban areas with hit skips or hit and run crashes, they are shown to have higher rates of hit and run accidents involving children. Crash characteristics illuminated by environmental factors, including lighting, roadway geometry, and location of the crash, have been shown to be associated with the likelihood of hit and run crashes. And I've seen, and I don't know if it's because I'm looking for it, but tons of headlines about hit skip crashes in Cleveland that involve children. And I can't help but not think that it's environmental factors and lack of intentionality with the roadway geometry and lighting and all of those things that are compounding that right outside our front doors. Okay, so with violence, Mayor Bibb is taking the rise in gun violence seriously as officials from Cleveland held a press conference this past Tuesday, actually, to address the notable spike in gun violence. And he cites the irresponsible handling of guns has resulted in 61 deaths to date this year, regardless of age. So we're talking from babies to older adults. And proposed solutions are requiring officers to spend 1 hour watching the streets and more activities for youth. So making sure that the rec centers are open more hours and that there's more programming available for our youth. And then just yesterday, Dr. Elizabeth C. Gedlacki from The Cleveland Clinic penned an opinion piece analogizing effective gun violence prevention to other risks. For example, she writes, if I tell you based on your personal health profile that taking a statin every day will decrease your risk of having a heart attack or stroke by 20%, that is a pretty good risk mitigator. The adverse event would still occur, but why not reduce the risk? Later in the piece, she poses the question, why then do we fail to apply this logic to sensible evidence-based interventions in gun policy? So that's some food for thought on a local, and of course, all of these things apply at a national level too. And then when we think about opportunities to achieve optimal health, what is optimal health? It's a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And in this chart, clinical research, generally speaking, is the study of health and illness in people. I know we had a much longer definition in the beginning, but it's how we learn to prevent, treat, and diagnose illness. The people who participate in clinical research are not immune to social determinants of health. The 5 key domains of social determinants of health are economic and social conditions that influence individual and group differences in health, economic stability, healthcare and quality, social and community context, neighborhood and built environment, and education access and quality. As we've learned when we explored the reality of health disparities, even the most educated and wealthy people of a certain racial or ethnic demographic cannot escape certain health outcomes that are driven by systemic inequality. Think infant and maternal morbidity and mortality. How can we achieve optimal health for all when we have so many challenges to overcome? One way is through clinical research. So what is health equity? It's the absence of systematic disparities in health or in major social determinants of health between groups with different levels of underlying social advantage or disadvantage. This definition of equity supports operationalization of the right to the highest attainable standard of health as indicated by the health status of the most socially advantaged group. To assess health equity, we must compare health and its social determinants between more or less advantaged groups. When we look at one way of achieving health equity being through clinical research and clinical trials, we must examine the current state. This chart depicts racial and ethnic demographics in the United States to Cuyahoga County, City of Cleveland, and clinical trial participants. And these, for the clinical trial participants, it's largely approximations because collection of racial and ethnic demographic data is not required for all studies. But I suspect that that will change in the near future. To advance health equity through research, we want to see at a minimum a reflection of the world. As an example, if Black or African-American people make up 13.4% of the US population, we'd like to see that figure reflected in clinical research and clinical trial participation. Even better, we would see figures that reflected the local community and the incidence of diseases and conditions in that community, regardless of whether that figure contradicts the national incidence. And now we have an interview to really personalize why diversity in clinical trials is so important.
Jaleese, I'm gonna stop sharing your, yeah, and then if you wanna reshare with your sound.
Thank you.
We're talking to Dr. Hannah Lemmerman about babies and sunscreen.
It's good for families to spend outdoors. While many families rely on sunscreen to prevent sunburn, it's not approved until baby is 6 months old or older. Here are some ways to protect your baby from sunburn. Keep babies younger than 6 months out of direct sunlight. Find shade under a tree, umbrella, or the stroller canopy. Try to limit sun exposure when the sun is strongest, from 10 a.m. to 2 p.m. Dress baby in light cotton clothing or a rash guard, plus hat with a brim. And remember to set a good example by practicing sun safety yourself.
medical research has accelerated in the wake of the COVID vaccine.
But as new medications and treatments for other diseases are discovered, there's one critical component missing from clinical trials: diversity.
And tonight, our senior health correspondent, Monica Robbins, reports on an effort locally to change that and why it's so important.
Rochelle Long dealt with Alzheimer's disease nearly half her life. Several family members suffered from the memory-stealing illness. She calls it dehumanizing. That's why 18 years ago, she enrolled in her first clinical trial, studying ways to combat the disease and her own risk.
I'm doing this for future generations, not just my own, because I wouldn't wish this on my worst enemy.
Jaleese Littlejohn Thomas is a community outreach coordinator for University Hospital's clinical research team. She's trying to expand the diversity of clinical trials that often skew white and male.
We have about 7% participation from our Black community and about 13% from our Latinx community. And then from there, the percentages are just negligible.
Diversity is critical because not all treatments work the same in every ethnicity.
Participation in clinical research could help bridge the gap of health disparities by ensuring that the risks and benefits of drugs, treatments, devices, and biologics are expressed and investigated across all populations.
Rochelle has been part of nearly half a dozen trials. She believes it's her duty to her family and all races.
If we don't get out there, then we won't know what will work. We can't sit back and wait for somebody else to do it.
Both women understand the hesitation among minority communities. Abuses decades ago still have lingering effects. But doctors shouldn't let that prevent them from asking diverse patients if they'd like to participate.
That doesn't mean that you don't give them that opportunity to say no, because one day someone will say yes, and that could change the trajectory for their entire generations.
It's not a guinea pig. You try new food. You get sick, you go to a hospital, you accept whatever drug they give you.
Rochelle says she never felt disrespected. If anything, she says she received better medical care because she was always being monitored. She's confident things have changed.
We have protections in place that address some of the historical abuses of special populations.
Monica Robbins, 3 News.
All right, and now we will move into our law and policy section. A law is valuable not because it is a law, but because there's right in it. Henry Ward Beecher. And as with anything in life that we aim to see results from, inaction or action without consequence is ignored. As historical mistreatment, abuse, and neglect have been penalized over the years, especially in biomedical research, moving past the insurance of basic rights, respect, and autonomy, we continue to see growth in the centering of diversity, equity, and inclusion in research. I'll discuss a few notable laws and policies that support this notion. The Nih Revitalization Act of 1993. So this directed the NIH to establish guidance for inclusion of women and minorities in clinical research, and it ensured that women and members of racial and ethnic minority groups were included in research, and also delineated some of the circumstances for which inclusion was inappropriate. For example, looking at the study design, the purpose of the study, and how it would be executed. And of course, with women, even looking at the subset of pregnant women and how there used to be that, well, there's still currently this notion that pregnant women should not be included in research because the risk is too high. That's why we don't have all of the information that we should at this point in 2022 about pregnancy and how it impacts women and child development. And then it also emphasized the operation of outreach programs to achieve aims. I did community outreach works at UH in the Clinical Research Center, and I can't tell you how important that piece of this is to not only recruitment, but just the education and awareness piece about clinical research, and how when you give people information about a process that's foreign to them, there's the empowerment piece, and then they really can make an educated decision for themselves and their healthcare. Section 907 of the FDA Safety and Innovation Act of 2012. So as you see, we're moving a little bit closer into the 2000s. This directed the FDA to investigate how well demographic subgroups were represented in applications for medical products, so drugs, biologics, and devices, and they had to be submitted, these plans, to the FDA for marketing approval. to make sure that they were included in clinical trials, and if there were some special safety and effectiveness data that was available, that was shared. The other requirement of this act was that the FDA had to provide Congress with an action plan detailing recommendations for improving the completeness and quality of analyses of data on demographic subgroups and summaries of product safety and effectiveness data, and in labeling on inclusion of such data or lack of availability of such data to patients, healthcare professionals, and researchers. Great example, I had asked my son's pediatrician if he had information about how a certain drug or vaccine impacted African-American males, because I had heard, I didn't do a ton of research on it beforehand, but I had heard that it impacted African-American males differently. And he didn't have any information about it. So this is just goes to prove that point, that people have questions about how it will impact them, especially if they do belong to one of these demographic subgroups. And this act is making sure that that information is available, or at least trying to elevate the importance of it. So the action plan that came out about a year after the act was released, the priority areas that were identified are quality, participation, and transparency. One of the major issues in clinical research is that we don't have great information, great data that's coming in about demographic subgroups. So improving the completeness and quality of that data is a paramount priority, but it's difficult because we don't have a streamlined way to both collect and then house all of that data and make good use of it. And then with participation, can't talk about this enough, but I constantly or consistently identifying and addressing barriers to participation and really making it a reality for anyone who wants to participate, regardless of their circumstances. And then with the transparency piece, where is this information made publicly available? So that's something that they're currently working on. And then the CARES Act, section 18115. So that's the Coronavirus Aid, Relief, and Economic Security Act. It had some minimum required data elements that must be collected and reported for COVID-19 lab tests. And it included patient age, race, ethnicity, sex, zip code, and county. So very important when we're looking at the social determinants of health and socioeconomics. And like we were saying before, just the subgroup demographics, that this is acknowledging again that we're still not collecting and reporting this information in a meaningful way. So if we could borrow some of the tenets that supported the CARES Act in this section, a lot of those principles would translate very nicely to clinical research as a whole. And then we have the Henrietta Lacks Enhancing Cancer Research Act that was enacted January 5th, 2021. Henrietta Lacks was an African-American woman. She was diagnosed with cervical cancer. She died at 31 years old. Medical researchers took samples of her tumor during treatment, and the HeLa cell line, the first immortal line of human cells, was born. Her cells have been used to study and develop vaccines, including polio and COVID-19, and drugs for treating cancer effects, HIV, AIDS, hemophilia, leukemia, Parkinson's disease, all without remuneration, and all without her family knowing that this had been going on since her death. So the requirements for this act are that the Comptroller General of the United States shall complete a study that reviews what actions federal agencies have taken to help address barriers to participation in federally funded cancer clinical trials by traditionally underrepresented populations. So that's all those subgroup demographics that we talked about with the CARES Act and with the NIH Revitalization Act of 1993. And then to identify those challenges and implement any actions that could lower those barriers to participation. And then to identify additional actions that can be taken by federal agencies to address barriers in federally funded cancer clinical trials. And then the final piece of this act is that a report must be submitted to Congress on the results of the study, including recommendations on potential changes in practices and policies to improve participation by underrepresented populations. And then we have the Diverse Trials Act. So DIVERSE stands for Diverse Investigations via Equitable Research Studies for Everyone. And this act is not currently enacted, but if it is enacted, it will require the Department of Health and Human Services to issue guidance on how to conduct decentralized clinical trials to improve trial access. So the way trials work now, if you were to sign up for a trial at, say, the Cleveland Clinic, Metro Health, or University Hospitals, you would likely be expected to report to a site, if not the main campus, for your infusions, if you're doing something with a drug or a treatment. And that transportation barrier, the time, just all of the things that we have to deal with in our personal lives would be compounded by involvement in the clinical trial. But we're looking at ways to decentralize that, and this act would support that. And then, of course, encouraging diversity in trial enrollment by exempting free digital health technology that enables trial participation from the anti-kickback statute. It would also allow the Department of Health and Human Services to issue grants to enter into contractual arrangements to support education, outreach, and recruitment for clinical trials. And these are for diseases that we're seeing, that are health disparities, the ones that Dr. Hall referenced, and so many others that are impacting our underrepresented populations. And then it would build on the CARES Act, which we just went over. Those data collection requirements are key because without data, we really can't make informed decisions. And then finally, it would create a statutory safe harbor for patient support, which can be a critical factor for some lower income patients in deciding whether or not to participate in a trial. And thank you very much. If you have any questions, you will have these slides. You can contact me at jalise@case.edu. And Ashley, the floor is yours.
Elise. So I was keeping an eye on the chat. So a couple of the things that I'm going to talk about are going to answer a few of those questions that were presented. Before I do that,
can you take yourself off mute?
I am not showing myself on mute. Can you hear me? Is everyone able to hear me? Oh, I can hear you. Okay. So I'm first going to start with the traditional legal disclaimer. My name is Ashley Keith Phillips. I am Assistant General Counsel here at University Hospitals, but the information I'm going to present to you is not going to be specific to UH, and it is not considered individual legal advice. It's general information for you to be able to receive for this presentation. I won't be able to counsel you directly, but I can certainly answer general questions with regards to this topic. So first, I would like to talk a little bit about the legal framework that is in place as a result of what Jalise spoke to earlier about the lack of protections that were in place for patient populations historically. So there's a question in the group chat about how do you know if the clinical trial that you're participating in is valid? How do you know that this is an actual real trial and there's not just someone trying to obtain your information or your biological products? So if you go to clinicaltrials.gov, any clinical trial research that's funded either in part or in whole by NIH is going to be registered there. You can go there and you can look at the study, the principal investigator, and the nature of the trial, which phase it's in. So phases go in numbers. For example, a phase 1 trial is very early human research versus like something all the way at the end of the spectrum, which could be a post-market trial, which would be something like an evaluation of something that's already on the market and you're trying to determine if instead of a treatment plan that takes a course over 30 days, instead you should have changed it to a 60 days, something that's already FDA approved. So clinicaltrials.gov is a legal requirement for those studies that are funded in part or in whole by NIH. In addition, there are going to be some FDA requirements because the FDA is the body that's required to regulate human trials here in the US. So one thing that you always hear about are these serious adverse events that get reported in the news. This clinical trial took place and there was one serious event reported to the government, and here's the information that's available. Serious adverse effects are defined by the FDA, so they include the following items. It's death, which obviously is very at the top of the list. Anything that is going to be considered life-threatening, a hospitalization of a clinical trial participant, disability or permanent damage to a participant, congenial abnormality or a birth defect if the patient is pregnant or in the process of delivering or breastfeeding. Intervention, which was needed in order to prevent one of these types of permanent impairments or severe damages, and other serious events. The great thing about the FDA is that in addition to the site and the sponsor, so the sponsor is going to be the person within the industry that's paying for the other portions of the trial. So those are going to be like the Moderna for the COVID vaccine or the Pfizer Corporation. They have independent reporting obligations. And there's also the opportunity for clinical trial participants to report to the FDA directly any serious adverse events. So if you believe you experience a serious adverse event during the participation in a clinical trial, you can contact the FDA directly, even if it did not get reported by the site or by the sponsor. So there's a legal framework in place in order to do that. In addition, there are also Hipaa obligations for the healthcare provider who's going to be the covered entity. I won't go too far into that because that's a separate HIPAA presentation probably, but the covered entity, which is the hospital, the healthcare provider, are required to stay within the confines of the authorization for the personal information that you provide to them. So it's going to list out all of the information, one, that you're providing, and two, that they are allowed to share as a result of your participation in that trial. And then as a participant, you will also have to complete an informed consent form. It will not be a blanket, very general, broad saying, I consent to participate in this trial. It's going to spell out the unique risks of participation. It's going to include the information of how to report it if you have questions or concerns, and it should have a compliance component. So all of those things are legal frameworks that are in place in order to protect individual participants, to regulate the administration of these programs, and to ensure that the patients who participate have multiple avenues in order to have their health protected and evaluated over the course of the trial. So you can find that information. It's publicly available. Again, you can access it. And you can also make your own complaints when there is a HIPAA violation. And the Office of HHS will investigate HIPAA complaints independent of the clinical trial regulation. So you do have all those protections in place as a participant. There are all these obligations on healthcare providers and industry sponsors in order to comply with those. And if you participate in a clinical trial, or you have concerns about it, or if you have questions, or you're looking to participate, those are resources that you can utilize that are available to you, publicly accessible on the government websites, in order to be able to know whether or not the trial is valid, is being performed reputably, and it's in compliance with applicable federal and state law. So I see that there are quite a few questions. I'm going to mute myself and allow the questions to be reviewed or answered. And if there are any questions specifically for me, anyone is more than welcome to type my name next to something if they want to ask me, and I'll unmute myself to be able to address it. But I see there are some in the chat as well as some in the Q&A section.
I want to make a quick point. It's the reason, equity and all that is good. And people think they do it just because it kind of makes the world a better place. But what the last 2 years have shown us, because of the pandemic, because of the inequities that existed, because of the lack of trust that existed, that's why we had a pandemic that's lasted 2 years and 3 years. Like, why? Because we have pockets of our population that didn't trust and didn't believe, and big pockets, right? And that's why the virus had an opportunity to change and mutate as it goes from person to person. Because if you have populations that are not isolated, they're mixing with the populations that are vaccinated, and yet we still couldn't get out of it. And so this has shown us that the human race, we are all in this together. Across countries, across the world, we're all in this together, and we cannot exclude a population and then hope assume that there's no ramifications, because we've seen the ramifications of distrust and the ramifications of a whole lot of people being not vaccinated when the really bad version of COVID was circulating and people were dying, and still the trust wasn't there. Seeing people die, seeing the death rates on TV on a daily basis still didn't move a whole lot of people. And so, so being able to be inclusive and include people who don't have an opinion just as yours, didn't grow up like you, doesn't believe the same things that you believe in terms of religion, all those people need to be at the table, so that when we need to come together to make some mass move like we needed to with the pandemic, we can help save ourselves.
So Dr. Hall, I think this first question in the chat is for you. Why do Black populations have a lesser life expectancy and the worst outcomes? What are the contributing social factors?
Well, we could do a whole nother hour on that, right? That's an easy question. No, it's a whole lot of issues. There's access, there's trust, there are some genetic issues, there's treatment, there's just a long list. It's not just lack of insurance, or it's not just poverty. Obviously, I'm a doctor, African American, so even though I'm a higher socioeconomic status, I still have a much higher chance of dying from from prostate cancer or cardiovascular disease than the poorest white person in Northeast Ohio. And so those sort of disparities, we have to try to figure out why is that? And I still try to eat good food and I still try to exercise, and yet that's still there. What is all that about? And people have a lot of hypotheses about what that is. But the one thing we know is you can't just say, well, it doesn't exist. You know, I mean, which still, you know, some people say they're not health disparities. Black people aren't at a disadvantage. What are you talking about? You know, I just recently saw that on TV. It's like, what are you talking about? Black people, they're not at a disadvantage. You know, and so I actually thought, yeah, we are, you know, but it's just funny that if everyone's nodding their head, yes, you know, but know that there are people that don't believe that. There are people that don't believe that. And so we have to kind of keep saying it. There are health disparities, and here's the data. I had a doctor ask me when I presented the data I showed you this morning, well, where'd you get that from? Well, everyone gets a death certificate, right? When you die, everyone gets a death certificate, and everyone has to have a doctor say what they died from. And so that's where that came from. So that that's not fake news, right? That's you know, that's census data. That's not census data, but that's federal data. And so it is what it is. And so it'd be nice if it wasn't that way, but it's not. And so since it's that way, we need to figure out why. And you know, my other big pushback is, well, you know, race is just a social construct. It's just a social construct. There, you know, ignore it. Well, if we ignore it, the social construct is going to continue. The disparities are going to continue. And if we don't measure it, what happens to Black women? What happens to, you know, Hispanic Latino men? If we don't know how they're classified, we can't even make a targeted intervention. So we can't just, you know, rise above, oh, la-di-da, it's just a social construct. If I ignore it, it'll go away. Well, it hasn't. That approach has not worked. You know, it may be a social construct, but it's a social construct that has hard health outcomes. It's a, you know, and maybe the social construct is oppression, and oppression causes cortisol levels, and cortisol causes obesity and heart disease. And maybe that's the answer, like some people have suggested, right? That, you know, if you oppress rats, you know, they have a shorter life expectancy than unoppressed rats, right? I mean, that's a fact as well, right? And so, but to just ignore it and say, well, if we stop measuring it, it'll go away is not a good approach.
Thank you. And I think this next question is for you, Ashley. When encouraging someone to participate in a clinical trial, I wonder, does a participant in a clinical trial have legal rights to be informed about the progress of the trial? Any legal right to be offered a new treatment that comes out of a trial you participate in?
So the legal right to understand the progress of the trial. Typically, there are going to be some constraints on the information that you can release to the participants in the trial. You do not want them to start to have, you know, self-reported internal biases in the process. Like, oh, I'm actually on this drug, and you know what? I read somewhere else that the side effect is that, and I woke up this morning and now I have that side effect too, right? So there are certain things that you don't want to disclose to the participants because you want them to participate blindly and accurately and completely report the information. There is the option to be able to stop to participate in trials, but there's always going to be a patient safety qualifier within that framework. So you usually have a way to safely remove from a clinical trial, or you have to disclose to the patient that they cannot be safely removed from the therapy for whatever reason, and that this is, as a result, this is going to be the course of treatment. So patients do have certain rights, but it's going to be limited based on the integrity of the study, and also based on patient safety. Now, do you always have the ability to say, I'm going to get discharged against medical advice, even though they say it's not safe for me to be removed off this medication? I'm just going to cold turkey quit it and stop it, and I'm never coming back to this hospital. Yes, people can always do that, but those are not the scenarios that we want to do. So when it comes to enrollment in those processes, when it comes to that informed consent that I talked about before, that should spell out all of the ways in which the study can be wound down, the ways that it can be terminated early, and the ways that you can discontinue your participation if you decide you no longer wish to participate.
Okay, excellent, thank you. And I think this will be our final question, just so that we get everyone out of the virtual room on time at 1 p.m. We've talked about addressing the institutional inequalities in healthcare, health disparities. Does anyone know whether there has been a movement in medical schools to address these issues through coursework, particularly in required courses? Dr. Hall, I know you said that you teach a few courses anything from that angle. And I'll just say very quickly too, from the School of Medicine perspective as a whole, there is a whole DEI office that is working on this. They have a graduate medical education advisor. So I know that there's work being done. I just don't know the current state. What do you know, Dr. Hall?
Well, I mean, yeah, there's a lot of work. It's all the rage now, right? And so we're hoping that it embeds itself and really, but there's a lot of stuff to learn in medical school, and a lot of people have pushback. We've got to learn biochemistry. So where does this rank next to biochemistry? Where does it rank next to pharmacology? There's more medicines now than there were when I was in medical school 30 years ago. So where is the importance of DEI compared to pharmacology or oncology? And so they're asking these questions, and sometimes it gets bumped. So is there a lecture on it? Probably not. Is there an elective? Probably. And so who's going to take the elective? It's kind of like preaching to the choir, right? We're trying to show that how critically important it is, and that maybe it's as important as biochemistry. I'm going to see patients this afternoon, and I guarantee you, me dealing with African Americans and earning their trust is more important than biochemistry this afternoon. For me, I'm laughing, but I'm not joking. It's far more important that I be able to connect with people and have them trust me and have them believe me and apply that research that's been balanced than it is for me to finish a biochemistry equation properly, because that's just not what I'm doing this afternoon. So so we've got to try to empower the people in power to be able to look at that and say, sort of answer that question.
All right, thank you very much.
Mm-hmm.
So now, Dominica.
Thank you guys so much for taking the time to speak on this incredibly important topic. I hope our audience has some great takeaways. How could you not? I will get the CLE survey out to everyone for credit to those who need it. But thank you again so much for taking the time to speak about this. Hopefully we'll have some follow-up discussions. And yeah, have a great day, everyone. Take care.